Hello everyone, and thank you for taking some time today for our first South Australian Policy Summit for Palliative Care. We appreciate everyone jumping online today to listen to this very important topic, and also to all the speakers that have given up their time to contribute to the conversation today. So I'd like to start by acknowledging the traditional owners of the land where we meet today and pay respects to elders past, present and emerging. Recognise anyone in this forum today with First Nations heritage, and also to acknowledge any sad news or sorry business that may be happening on the lands and seas around us. So I'd like to hand over to, or first start by talking about the housekeeping for today. So technology, we've all been dealing with technology for quite a while, and hopefully everything works, but we all know sometimes it doesn't. So please be patient if anything happens. Please put any notes, a note in the chat area if you've got any issues with the sound or visual as well, so that we know and we can respond to that. We will have a Q&A chat, which you can see at the bottom of your screen. So please feel free to ask questions there. It is a very quick program over today, so we really appreciate everyone. If we can't get to your questions during the session, we will respond to them and collate them after, and we'll be sending an email to everyone after with the slide deck, with the slides. We'll also be putting this up on our YouTube channel, so you can watch it later as well. So there's lots of ways to re-engage with today's session. And we will be recording today's session, so thank you all for your patience in allowing that to happen as well. So this is the program. You can see it's a pretty jam-packed program. We'll try to keep to time as much as we can. And we've got speakers from national and state coming from all different places to present today to talk about palliative care in South Australia and what they're doing on different scales on a national, a local and a state level as well. So it's quite a lot of different people. We will be having a lunchtime break, so you'll have a time to be able to get some food and have a bit of self-care, and then we'll come back for the state session after that. So the first session up is national session. Okay, so now I'd like to hand over to our wonderful chair, Susan Emerson, to open today's session. Over to you, Susan.
Thank you, Shyla. On behalf of Palliative Care South Australia, I'd like to welcome you to our very first Policy Summit. Today is a really exciting day for us as we bring together experts in leading programs from across South Australia, interstate and overseas, to provide their updates, insights and thoughts on policy priorities for palliative care. From clinicians to members of our community of care, in today's session, you will hear from diverse voices who, like us, share the common goal of ensuring that all South Australians facing death and bereavement are supported to live, die and grieve well. With this shared goal in mind, Palliative Care South Australia will use the information presented today to create a series of policy positions that we can all use to advocate for positive change, education, funding and programs to support the communities that we serve and to ensure that palliative care is viewed as an essential part of life. In a sector with limited resources, we believe that this approach will provide a collective voice for the sector, enabling Palliative Care South Australia to fulfil our role as the peak body for our sector, its people and providers. Held every 2 years, with alternating years being the Palliative Care South Australia Conference, we believe that today's session and ensuing conferences will play a pivotal role in supporting each other as we work together to improve our sector for all. Thank you for joining us today. On behalf of the Palliative Care South Australia Board and team, thank you to our Palliative Care Australia colleagues who are joining us as well. And I'm excited about what we'll hear today and where we can go together in the future. Thank you, Shyla.
Thank you so much, Susan, and thank you to everyone else that's presenting today. I'd now like to introduce our first speaker, Camilla Rowland. Camilla is the CEO of Palliative Care Australia. Now, in the interest of time today, I won't be reading everyone's bios, but they are on the screen at the beginning of this while they're logging in. So you'll see them there. And thank you so much to Camilla to get us started for today and get the ball rolling. Over to you, Camilla.
Well, good morning, everybody, and thanks for having me, Shyla. This is actually really great timing to be able to talk about what's happening at a national level, because as you can imagine, post-COVID and with the current new government, there are some pretty strategic discussions being held. So if we can move to the first slide. Thank you. So the palliative care roadmap, which we developed before the federal election, still stands in good stead. It's actually quite complex and it's quite detailed. And many of you had input into that roadmap for how palliative care should look forward into the future up to 2027. We have been updating that each year, and we will look at it more strategically in another year's time. But what I can say is it still connects to the aged care reforms. It connects to new governance arrangements in the era of the National Cabinet, post-COAG, and there's transparency in funding and progress against systems. So let me just expand on that a little bit more, staying on this slide, is that we know that the Assistant Minister for Health, Jed Carney, is really passionate about palliative care. She talks about, although she hasn't worked in palliative care, she's worked with palliative care when she was a when she was a registered nurse. So although her portfolio isn't specifically clear, she seems to be taking a leadership role in the palliative care space, and Mark Butler seems to be taking a more secondary role at this stage. We also know that in talking to her, that she's aware that the National Palliative Care Strategy Implementation Plan should technically be completed next year. So we're looking forward to conversations with the Department of Health and Aged Care around what does the future of the implementation plan look like. And a lot has happened since the strategy was written and promoted in 2018 around some of the imperatives that are interconnected with palliative care. So let's talk about what those are if we can move to the next slide. So the mounting pressures on palliative care are really focused on, first of all, voluntary assisted dying and the implementation of voluntary assisted dying. We know that we've only got 2 territories to go. We've also heard recently from the Northern Territory that they're not likely to look at voluntary assisted dying for another couple of years. It's not high on their agenda. And ACT is starting to embark on the thinking around voluntary assisted dying. What has that meant for us nationally? It's meant that there's a variety of implementation challenges, and there's been a misconception often by the public and the media that voluntary assisted dying and palliative care are interconnected as one service. We're doing a lot of work in communications to try and dispel this myth, to make sure that people see them as 2 separate services. That actually has some impact on people being able to access palliative care. So what we're trying to do is a comms communication strategy by saying everyone should have access to palliative care when and where they need it. We know there's a postcode lottery in relation to palliative care, but we want to ensure that people can access it and that people aren't necessarily then forced into a situation of choosing voluntary assisted dying. And when we talk to our colleagues in Canada, that is one of the issues they have faced for the last couple of years, that in fact palliative care is not available everywhere, such as like in Australia, and the incidence of voluntary assisted dying increasing in areas where palliative care has not been available is of concern to them. So we are very aware that that is an issue we need to continue working on. The increase in 65 plus population, when we talk to federal ministers or shadow ministers, they say that is our burning deck issue. We need to be very aware that as our ageing population increase and there's more pressure on the aged care providers and on the residential aged care facilities, we need to ensure that we have palliative care available in those settings. So that is another area. We're also aware the timing of that with the aged care reforms is critical, and that will continue over this next year or 2 in terms of needing to have palliative care embedded in the aged care system. The economic headwinds from the May budget, we were very conscious that there was very little new investment into palliative care nationally, that most of the investment, in fact, there was very little in most health specialties. Most of the investment's been in My Medicare, primary health, hospital system reform. And we hear from the minister, the assistant minister, that in the next budget, there will be more focus on specialty areas such as palliative care. Workforce shortages are absolutely still critical in all states of Australia. We hear there's very little money for backfilling. We hear that often there's fly-in, fly-out staff. There's lack of continuity. And we're very much contributing to the Care Economy Task Force around workforce. And and still monitoring that COVID impact. We're still involved in the National COVID Task Force. Can we look to the next one, please? So we want to ensure that not only are we investing in specialist palliative care, that we are also focusing on palliative care becoming core business in aged care, primary health reforms, ensuring there's a greater integration and connection between primary health and palliative care. And of course, now with the Disability Royal Commission, ensuring that people with a disability can access palliative care, because we understand and we hear that there is low levels of access to palliative care for people with disabilities. And it's more about not a problem with palliative care, not recognising it, it's more about whether they're getting the referrals at the right time and the right place. So if you think about if you had to say, what was the one slide from this that you can take away from today, that's where our focus areas are for this next year to 2 years. Next slide, please. So with specialist palliative care services, we're completely aware that the fragmentation and the wide variation of integration between specialist palliative care and other health specialist systems across Australia is very fragmented. And if we were to do a map of what those systems look like at the moment, they vary from region to region, from state to state, and from territory to territory. We're trying to find what are the common threads and the common ground that exists. And projects like Greater Choices should start to raise what are bespoke or local health-led area initiatives that meet the community need versus what are the key elements we need to maintain. We're aiming for that local hospital network-led multidisciplinary outreach service, but how does that include specialist palliative care? And again, that's extremely variable at this stage. The National Health Reform Agreements we're organising submissions to, and that's really looking at what is going to be the balance between Commonwealth funding and state funding in each state, and what do those agreements look like in relation to palliative care specifically, because again, it's incredibly variable across Australia. But we also know that the government's concerned about the number of people having inappropriate hospital admissions, and how do we enable them to fund focus of palliative care in community and in aged care facilities as well. Some of the models that are now being looked at are things like value-based healthcare. So, that's some years away till that sort of modelling is resolved, but we need to start looking at what are some of the incentives to keep people out of hospital, but at the same time, what are some of the funding mechanisms? Can we have the next slide, please? Palliative care and primary health. We talked about a postcode lottery. General practice is critical. We know particularly in rural and remote areas, there's often nothing other than GPs and community nurses and local care services. We're trying to ensure that in those regions we have outreach palliative care with a combination of telehealth, face-to-face outreach, making sure that with large regions there are palliative care services based in those larger regions. But the high rebates, especially for long consultations and for bulk billing for GPs in rural areas, is now being addressed. What I do hear from some of the rural and remote GPs, and I met with a group of them in Northern Territory, in remote Northern Territory last week, is that still doesn't address their travel components and their accommodation components with people who are remote. So that's just something we still need to bear in mind as we think about that bulk billing for GPs. Can we have the next slide, please? So palliative care and aged care. We know, for example, through projects like LDAC that, there are 107 aged care facilities that have palliative care and end-of-life planning embedded. But with almost 3,000 residential aged care facilities across Australia, we know there's a long way to go to ensure that palliative care is embedded. We're still at a cultural change period of time where aged care facilities don't see themselves as subacute care providers. And having just come from the National Dementia Conference last week, we can still see there's a long way to go with aged care providers to ensure that palliative care is part of their thinking and part of their practice in terms of care in aged care facilities. Can we go to the next one, please? So there are a number of streams of reform. Just to give you an update about where things are at, you can see the list that's been ticked off about new codes of conduct and star rating, new aged care standards being worked on, new regulatory model. There's many streams of reform, but they are broader governance and systems issues. We have been doing a number of submissions over the last few years, and they continue into each of those elements to say palliative care needs to be embedded, to make sure they have a great understanding of what end-of-life care is versus palliative care, and to understand where palliative care should fit into their systems. The next big task coming up is the new Aged Care Act, where we'll have quite a lot of input into that. Can we have the next slide, please? So our priorities are definitely delivering on the Royal Commission into Aged Care's ambition to embed palliative care in aged care, through initiatives such as LDAC promoting that, certainly advanced care planning, looking at models of how palliative care can be part of in-reach or outreach, but particularly we want to make sure that palliative care is embedded in terms of the training of the workforce in aged care, and very much advocating for that role. Building on primary care reforms to increase access to palliative care. So that's actually working with the primary health sector to ensure that they are making referrals to and visiting aged care residents at home or in aged care facilities to ensure that access to palliative care is increased. May I have the next one, please? Lastly, this is, as I said, just coming on the radar in the last year to 2 years about people with disabilities accessing palliative care. We know from talking to the major peak, National Disability Services Australia, that they're concerned themselves, and they've been doing some research on looking at policy research on how people are referred into palliative care, the timing of that, and about their own workforce, and whether people are recognising the signs of death and dying, or even of deterioration of somebody who's got profound disabilities. So we will actually have a focus of that at our Oceanic Palliative Care Conference as well, about what does that intersection or that interface look like between palliative care and disabilities. Could we also have the next slide, please? So workforce, that's our number one issue for our palliative care sector. We find for example, talking to Alice Springs, that the majority of their staff, whether it's nurses, social workers, doctors, are fly in and fly out. So even just forgetting rural areas and remote areas for a moment, it's a major issue in terms of our city workforces as well, that people are, the turnover of staff is quite considerable now in our specialist palliative care services. So we want to focus on that. We want to focus on people being trained in other areas that interface with specialist palliative care to ensure that we start to build that workforce. We also need to attract people to working in palliative care and look at our marketing approach as a sector. The National Care and Support Economy Strategy, led by the Department of Primary, it's not the Department of Primary Minister, sorry, it should actually say Prime Minister and Cabinet, apologies. So Prime Minister and Cabinet, this is a major concern of Anthony Albanese's Prime Minister, and he has looked at establishing a task force to look at our future, the next 10 to 20 years of our care economy, which actually, when you look at aged care, disability, early childhood and veteran services, they've specifically in their draft strategy included palliative care, because they understand the majority of palliative care is delivered in the community by various different health and community care specialties. We're really fortunate that that's been included, because it shines a spotlight on palliative care, and it means that they're recognising that the majority of people do want to die at home or in a residence of their choice, whether it's an aged care facility or a hospice or other. We believe that that care economy strategy will be, the final strategy will be launched in the second half of this year, and from there will be a number of roundtables and projects to help build our workforce. Can we have the next one, please? So that's the end, and I've gone through this very quickly to enable opportunities for questions if anybody has any.
Lovely. Thank you so much, Camilla. I think it's really important to see the opportunity to collaborate at jurisdictional and national levels, and a lot of those issues that You mentioned particularly around the disability area and aged care issues that we're dealing with at the state level. So really excited working collaboratively together with PCA in this space. There was one question, and I was just starting to respond to it in the chat area. It was talking about end-of-life doulas and the role there. So I'll just respond to that, and I'll put a link up into the chat. So Palliative Care Australia and the jurisdictional peaks actually have been collaborating over, it's almost 2 years, I think we've been doing this. And we've released a fact sheet, which is on Palliative Care Australia's website. And there's also a questions sheet. The fact sheet's called End of Life Doulas and Palliative Care. And the questions, which is for consumers and community members, is 10 questions to ask, your recommended questions to ask end of life doulas as well. So we encourage everyone to have a look at those areas. Is there any other questions for Camilla? Camilla, I think one of the big exciting things is the Oceanic Conference, which is coming up very soon. So hopefully everyone's getting their tickets and flying to that. Who are the keynote speakers? Can you remind me?
Oh, wow. So we have a whole list of keynote speakers, but I can tell you that we've got Xian Xiao from an internationally well-renowned speaker talking. We also had people like Professor Dorothy Key from Cancer Australia talking about the new cancer plan, but also where palliative care fits into that. We have people like Brendan Murphy, who's been the Secretary for the Department of Health and Aged Care, who's actually retiring from that role, says he can speak freely to talk about where palliative care fits into the healthcare thinking of the future. We've got some fantastic people like Dr. Sue Curl, who'll be talking as well, and that interface between palliative care and aged care. So look, I should tell people we've got an enormous number of scholarships. We have more scholarships available than we've ever had before. So if people are having some monetary difficulties or funding issues in attending, please have a look at the scholarships. So we've actually got 650 people registered so far for the conference, so we're really excited. But it gives us an opportunity to look at some clinical research that's been happening, some practice, that holistic sense of palliative care, but also there's interconnections into primary health and into aged care and into disabilities, and into culturally and linguistically diverse communities as well.
Sounds great. It'll be exciting to get everyone back together again up in Sydney, and hopefully we're all pitching to try and get an eventual one back in South Australia again. So looking forward to that in the longer term as well. So thank you so much, Camilla, for presenting on that. And now we'll move on to looking from AMSPAM. So AMSPAM is the Australian and New Zealand Specialist Palliative Medicine Group. And so we're delighted to have Christine Mott present. So over to you, Christine.
Hi and good morning, everybody, and thanks so much for the opportunity to chat about Australian New Zealand Society of Palliative Medicine. Are you able to bring up my slides for me?
Just 1 minute. It's just a little technical issue, so we'll just hold on a minute.
No problems. I'll start talking anyway. That's all good. So I'm Christine. I'm the current president of the Australian New Zealand Society of Palliative Medicine, and we are you can see our statement there that we support the professional needs of medical practitioners as they work to improve the health outcomes of every person with a life-limiting illness and their family or whānau in Australia and Aotearoa. And I am a consultant in pediatric palliative medicine. So, really trying to get our organisation to be a true kind of all ages society has been one of my goals as the first pediatric president of the organisation. And hopefully I'll get my slide in a second because they're very pretty. I've based some of our presentation today on our strategic plan, which runs from 2022 to 2025. And address some of the questions that were put to us about what we do to support South Australians and the things that are coming up for us in that space. I can share my version if they're not working.
Yes, that would be wonderful. Thank you.
Yeah, no worries. Hang on 2 seconds.
The patience of technology. Thank you so much.
Give me 2 seconds. If I can work out how to share, actually. Where is that option? Share, okay, there it is. Oh, it's disabled.
Working on it.
Yeah, I think it's disabled, unfortunately.
Should work now. Try that.
Oh. Aha, thank you. Does that work?
Perfect. Thank you.
Okay, so I did just touch on our purpose, which then we'll just pick that a little bit apart. So we are an organization that supports medical practitioners specifically, but not just palliative medicine consultants. It can be anybody, any doctors who have got an interest in palliative medicine. So that includes general practitioners, any subspecialists, generalists, and it does have the subspecialist palliative medicine in as well. And that does tend to be who sits on our council. So we are a council-based group with a CEO, and we are between CEOs at the moment, but we hope to be promoting our new CEO soon. So looking to improve health, and as part of that, we really acknowledge that we want some measurable health outcomes. We want some concrete ideas to be able to show our impact and our importance and areas that we need to focus on as gaps. We also, have a broad remit to look at any life-limiting illness, and we acknowledge that we are trying to be all ages and make sure that that is available from pediatrics right through to recognizing the growth in aged care. We are Trans-Tasman organisation, so we do work across Australia and Aotearoa, and so bring together the resources and the kind of collaborative working across both of those. And equity is very important to us, and I'll talk more about that. So there was a question about our reach. So our members are medical practitioners working in or with an interest in palliative medicine, and we do also bring out conferences which are yearly, and these are focused on topics of interest developed by our members, but actually they often have a wider kind of accessibility. So we do have nurse practitioners in particular who want to come to our conferences, and we have supported more multidisciplinary attendance at those, kind of depending on what their interest is on a particular year. How Palliative Care South Australia members can get involved. It's easy to join online through our website. And if you encourage your medical colleagues to join online, that was fantastic. Thank you. How many members we've got, you can see the breakdown there of how many in Australia and New Zealand. And this was our total at the end of the financial year last year, so 575, about a fifth to a quarter of those in New Zealand. So how we work, what we are focused on, these are kind of 4 areas that we focus on. So advocacy is a big part of what we do, member representation, non-member collaboration, and seeing ourselves as helping to steward the specialty. And I'll talk more about these, about how that's kind of how we work that and how we do those things. So advocacy, we provide submissions to inquiries and consultations in priority areas to palliative medicine. It's very flattering that we get many requests for input, and so we do have to triage those and pick really the ones that are most closely aligned to palliative medicine, or where there's the biggest gap, we think, for our specialty. And these can be submissions as requested by collaborating organisations. We work very closely with Palliative Care Australia, as requested by governmental bodies directly, or as requested by our membership. So sometimes we have opportunities highlighted by our own members to us. We do specific areas of regular advocacy, so we provide a lot of trainee support, and that has been a lot of collaborating with the College of Physicians in the last year and 2. And obviously, voluntary assisted dying has been something that has sit, unfortunately, close to a lot of our members' working lives and their interests, and so supporting in that space as well. We have been very fortunate recently in receiving a very generous grant to set up the Rural and Remote Institute of Palliative Medicine. And that's just very early stages at the moment. We have got a project manager, and we are just working towards some timelines of development for that. So really excited to bring that, and obviously that will support South Australia also, as well as all the other regions of Australia. And some of the specific work we've done, we did help with some requests for supporting the Margaret Knott South Australian Palliative Medicine Training Grant. So we provided some input around the framework for that. This is just a list of some of the submissions that we've been involved with, which as a national body tend to be national, but there are a few state-specific ones in there. And they're all on our website. If anybody wants to have a look at the specific submissions, they're all PDF linked on our website. Oops. So member representation, we have a good range of committees. So there is a Aotearoa committee, and they work really closely with their Department of Health and with the Palliative Care Collaborative, which is a group in New Zealand bringing together different organisations in palliative care. We have an education committee, and that's recent. That's since our most recent strategic planning, and that has taken over some of the, and provided a focus for some of the webinar projects we do, and some of the other educational offerings we have, and making sure that they're really consistent and not doubling up anywhere. And obviously we have our conference committees to move those things forward a lot faster than the council is able to. We also have a range of special interest groups available for our members to also join and be a part of and collaborate through. Those being renal, pediatrics, general practice, rural and remote, respiratory and older persons. Obviously there was a COVID one, and we provided a COVID kind of guideline and had a support group through that time. We also have working groups. You can imagine that we're quite closely aligned with MBS and their items review working group, and providing input on what MBS cover for palliative medicine looks like. And we also have a palliative care medicines access working group as well. I'll talk a little bit more on that. And then we have regular surveys of our members. So we do an annual membership survey to understand what's important to our members and be focusing our work on that. And we have been working towards having a voluntary assisted dying survey to understand where our membership is at, because it is, there's a broad range of opinions and experiences from our members on this. Non-member collaboration, obviously we work closely with Palliative Care Australia and all of the state palliative care organisations. In addition to that, we work increasingly with the Australian Indigenous Doctors Association, RACP, particularly the chapter of palliative medicine. And so their chair of the chapter of palliative medicine sits on our council, and in conversely, our president, so myself, currently sits on the chapter as well, and we work really closely together. That also includes their training committee as well under palliative medicine, so we provide a lot of input through that. The College of GP, and various other organisations. We are also members of IHPC, APHN, EAPC, and the Western Pacific Group as well. So we'll work with anybody who would like to work with us. In terms of stewarding the specialty, we review, provide feedback for, and distribute research requests. So we do, as a council, provide specialist feedback on research requests and then distribute those. We provide a significant amount of education and events. So as I mentioned, there's the annual educational event. This year it's our Melbourne Medical and Surgical Update. And then that alternates with our larger, broader ANSPAM conference. We have very frequent educational opportunities. So we collaborate with the College of Physicians and provide 6 webinars through their program per year. And then we have offerings on top of that. This year we've had things like voluntary assisted dying workshop, and we've had a session on spirituality and palliative medicine. There's also lots of output from our committee in Aotearoa with monthly education. We are supporting the development of communication skills workshops, acknowledging that has been a difficult area for our trainees to access, with it not being available through the college for the last 3 years. And so we are trying to tie that together with some of our conference offerings and have that available. We've also started engaging with ADA on a cultural sensitivity training program for our members. And we are just being asked to provide a delegate for the refresh of the palliative training curriculum. So linking in with lots of other organisations. And then, you know, really trying to understand our own specialty and kind of develop within that, recognizing that we've come up with these 6 dimensions of best palliative medicine, best practice. And that when we did a refresh of our strategy, actually, we didn't think we needed to change any of this. So we're very kind of happy this is kind of covers some of the broad part of what palliative medicine is, including complex symptoms, ethics as part of our work, partnering, advocacy, communication, and decision support for our families. And then I just wanted to heavily promote the fact that our 30th year, 30 years of our organisation conference next year is in Adelaide at the National Wine Centre. And so for people to look out for that in September next year, and really hoping that we can bring together lots of national, international folks, and also lots of input from Adelaide and local colleagues there as well. And we are going to have our first paediatric plenary, so very excited about that. And then we were asked about our top 3 priorities, and it's really great to hear Camilla speak and see that we're quite aligned with some of what she says as well. So equity of access to palliative care is really, really important to us, and we think it's a real priority area for us. And that's in the context of voluntary assisted dying, you know, really working towards having equitable access to palliative care alongside those choices. Telehealth, making sure that there continues to be a focus on and support for telehealth to be adequately supported, resourced, and sustainable in all areas. Making sure it's accessible in all areas of Australia, all rural areas, all ages. The other thing that has become an increasing issue for us and a focus for us has been medicines access. So although that includes kind of that part equity as well, and making sure things are available anywhere in Australia and New Zealand, also recognizing that we've had increasing issues with accessing opioids. And so in the last couple of weeks, we've seen that Ordine is likely to be discontinued, and that's a huge blow to palliative medicine. And so working with other organisations, including the PCA and also the Society of Hospital Pharmacists Australia as well, and other organisations, and trying to advocate in that space on the back of having also lost MS Contin granules a couple of years ago now, Folcodeine and Genesta in the last few years. And then also our workforce. Very much agree with what Camilla says around workforce and how important that is, and making sure it's sustainable, equitably able to be accessed and resourced anywhere in the 2 countries, and that includes high quality care with training and support. And that's all I was going to say. If there's any questions at all, I'm very happy.
Thank you so much. It's amazing to see everything that's happening, and very exciting to see a self-care conference at a wine centre. Very cool. It's great for South Australia to have it down here. So thank you so much. And hopefully everyone gets their tickets for that next year in September. And yeah, thank you for dealing with the IT issues so patiently as well. Lots of fantastic information in there. And so now we'll go across to the nurses. So Palliative Care Nurses Australia. And we're delighted to have Dr. Aileen Collier join us from PCNA to share what they're up to. Over to you, Aileen.
Thank you, Shyla. Nina Marnie, I am sitting on the lands of the Kaurna people today, but recognise our nurses are in countries all over Australia. So yes, my hat today is Palliative Care Nurses Australia, and I'm here on behalf of Kate Swetnam, who is our president and is somewhere else in the world right now, and of course our full committee. Next slide, please. So we're a member organisation for all Australian nurses, and we're interested in engaging with all nurses, whatever area they're working in, not just specialist palliative care nurses. And you can see there that we're really about the sustainability of the nursing workforce. You can see themes here already, promoting the professional development of nurses, providing palliative and end-of-life care, collaboration, facilitating knowledge, research, education and policy across our membership. And really promoting palliative care nursing in what is an incredibly challenging environment. So I should say here too that we have extraordinary capacity of nurse leadership here in Australia. And so our committee, we've got nurse practitioner representation from every state, I think, apart from WA, and not the territories, but we make most of our partnership with nurses in those missing states. And myself and Kate Swetnam joined the committee only at the end of last year. So we're a South Australian takeover of the Palliative Care Nurses Australia Committee. And we met in Sydney the other week to re-engage face-to-face because we hadn't had the opportunity to do so in some time and really focus on what we were going to prioritise over the next few years. Next slide, please. So really, we're all about membership support. Our members, we have something around 500 members across the country. And myself and Kate are very passionate about engaging members at a grassroots level. We provide a newsletter with information about the sector, professional development opportunities, position vacancies, committee news, and also some general interest articles and what else is going on in the sector.
Progress.
Oh, I got a funny little noise there from Zoom. Sorry. So we're also, of course, on social media to engage our nurses. Workforce education is a big part of what we do, and a bit like ANSPAN, we have a conference, a biannual conference. We also have webinars. Recently, we did a whole lot of work around communication, and we want to try and give nurses around the country opportunities to connect with our really senior nurse practitioners and specialists to help build capacity and have opportunities for other nurses to tap into that resource. And we also have huge sector representation with the nurses' voice. The next slide shows a kind of broad brush of the kind of representation that we've had. And this is bearing in mind that we're all doing this in a voluntary capacity, and it's quite extraordinary where we've had that voice and representation, not only at a national level, but at a state level. And again, the issues where we're having to, I think, collectively really work together, like the medication issue that Christine has just spoken about. So important that nurses have a voice on that. We are also prescribers, and nurses as the largest workforce are at the very pointy end of these challenges with patients and families and communities in every setting. So this is just a kind of an example, if you will, of where we've had representation. Next slide, please. But I just really want to focus in, speaking on behalf of PCNA today, where it really are in trouble here, because we, like everyone else has said, our workforce is under significant pressure, and we are the largest, nursing is the largest workforce. And so wherever those nurses are working, we're going to have a significant issue. These numbers are slightly scary for me as we all get a bit older. Next slide, please. And I just really want to highlight that at that pointy end, our nurses are really, really under pressure. So we also have an aging workforce. We have nurses who, with increasing population needs, are really feeling like they've had a hard time the last few years, you know, converting to their work via telehealth, trying to cope with more and more reporting and new public management and health. And they're really feeling like they're often that there's no light at the end of the tunnel. And, you know, I met a nurse, a palliative care unit nurse last week on the ward. And she didn't say, Aileen, when can I start my PhD? She asked me, how did I manage to stay in palliative care for these 30 plus years? A junior nurse on the ward, a very passionate, kind, highly skilled nurse doing her master's, but really feeling the pressure of having to work with 3 other agency nurses on a shift, in a biomedical environment where junior doctors don't have an aptitude for palliative care philosophy. And so this retention of nurses is really, really a major challenge for us. Next slide. So when we look at the priorities, you won't be surprised, of course, that they are all focused on nursing, but very much because of the top 3 challenges that Palliative Care Australia and Christine from ANSPAM have already highlighted, that somehow we want to support the capacity of all nurses, not just those specialist palliative care nurses, but aged care nurses, practice nurses, wherever nurses are working. And to try and support nurses to work to their full potential and scope of practice, again, whatever level they're working at, wherever they're working at. And I think we also have an issue with leadership and advocacy skills. And so we, this year, we wanted to provide a small scholarship to bring our emerging leaders together and to try and support the leadership capacity of our palliative care nurses to promote equitable palliative care for all who need it, and to try and build palliative care communities of practice. I mean, we just heard from Camilla about the fly in, fly out in Alice Springs. And so how do we support that workforce going forward? And so that's really aligned with the International Council of Nurses Charter for Change about we really need to invest in our nursing workforce. Sorry, I'm sitting in Modbury Hospital and we get the we get the call overs. Yeah, so our top 3 priorities. Next slide, please. And of course, just a flag for our conference. We're hoping to lock in these dates in Melbourne in 2024. And we really, again, want to get back to trying to engage at a grassroots level. And our conference will be face-to-face, but also virtual, to try and reach as many nurses as possible. So watch the space for our conference. And I think the key message really is nursing is our largest professional workforce. And if we don't have a nursing workforce, we really don't have the care in palliative care. Thank you.
Fantastic. Thank you so much. And I think I'm going to have that hamster wheel visual in my head for a long time, thinking about what you've described there. I think it's a great visual of, you know, what all sectors are feeling in this space. I know it's a real challenge over these past few years, and it's about getting everyone together, like you're saying. And I think coming through with all these conferences and opportunities to collectively work together to support each other is going to be critical in this time ahead. So thank you so much. And now we'll move on to the paediatrics. We'll move over. Jen Hyson from Victoria has kindly joined us to talk about paediatric palliative care from PAPCAMS, which is the Paediatric Palliative Care Australian and New Zealand group. Over to you, Jenny.
Hello, everyone. Can you hear me okay?
Yes.
Thank you so much for including paediatrics in your day. And my name's Jenny Hinson. I'm the head of the Paediatric Palliative Care Service for Victoria, the statewide service, and secretary of PAPCANS. So I'm a bit of a plan C today, I'm afraid, but I'll explain more about as I go along. So really, it's just an opportunity for me to share with you what PAPCANS is, so Paediatric Palliative Care Australia, New Zealand. And I guess, you know, paediatrics is much smaller and younger as a sort of specialised area. And we started out, I suppose, every year in Sydney, John Collins, who I think was he'd hate it if I said grandfather, the father of children's palliative care in Australia, the first one and the inspiration for many of us who continue in the area today. And he would run a symposium at Westmead Children's every year, and that continues to this day. And on the back of that, we would just gather informally, because we were quite a small group to start with. And over years, a bit of a snowball effect, more and more joining us and younger colleagues who we'd trained. And we thought perhaps it would be useful if we formed a national group, which very much like the nursing crew is run by volunteers. And Dr. Sharon Ryan and Dr. Ross Drake are the chairs of PAPCANS at the moment. And unfortunately, neither of them can be here today. So I'm here to fly the flag. So PAPCANS is affiliated with Palliative Care Australia and has links to ANSPAM and PSANS, which you may be less familiar with, which is the Perinatal Society of Australia and New Zealand. Because as you can see there in these statistics, a lot of children, infants who die are very young. The greatest mortality is really in the sort of under 12-month age. And the perinatal space, I think, is a space that is taking more of our attention, because we can see possibly a need there that is unmet in many areas. So we cover the range, I suppose, from antenatal diagnosis of life-limiting conditions right through to 18-year-olds and even above, cover the whole gamut of those. And, you know, paediatrics is interesting, I think, because of the diversity of the conditions that affect children. About a quarter of the patients across Australia would have a malignant diagnosis, and the rest would have a range of non-malignant conditions, many of them very rare as individually, but together causing common kind of phenomena, I guess, in terms of predominantly neurological problems, neurodegenerative problems. So there's high levels of complexity, high levels of disability. So it's a little bit of a different space, and we felt that perhaps it would be helpful being a smaller workforce, I guess. So there's about 50 members. So I feel very humble when I listen to the nurses, who sound absolutely awesome. And we're doing our best in our spare time that we don't have to try and progress things for children's palliative care in Australia with help from friends who I'll talk about in a minute. And really, like many similar organisations, we're trying to be a central repository for professional expertise and knowledge. And so if an issue comes up and government or other organisations need to consult around, you know, children's palliative care, then they can ask PAPCANS for input. And we've had input on a number of things recently, which I'll come to again in a second. So there's a lot of advocacy and lobbying for children to be included in things, sharing of information and resources, development of standards and guidelines, as you would expect, trying to take a coordinated approach to research. Education is a big focus for us, and trying to strengthen international links and links within our own group. So, we're a great support for one another through work on shared projects. And a lot of this is about trying to be efficient, isn't it? We, rather than each of us developing our own guidelines for a certain scenario or our own resources, one state might take the lead and the rest will share. And that seems to be something that works really well when you have, a small but very specialised area. So I guess that the things that are on our mind at the moment, and Christine, I could hear talking about, and this isn't really covered on the National Action Plan, but I will come to this in a second. But something that I think has taken our focus recently is the issue of accessibility of medications, and very upset to see Ordine leaving the market and us not having that option. As you can imagine, with our patients often being very little or very disabled and needing to have medication through a peg or a feeding tube of some kind, Ordine has been a bit of a mainstay for us, especially since we lost MS Contin. So we just feel the options for us really dwindling. And I know the rest of you who are working in adult medicine feel the same way, and everyone's feeling very passionate about it. But I think at the moment it's a really, really big issue and a very, very sad thing to see. I think, Ordine is on the WHO list of essential medicines for children's palliative care. And here it is in our country, with us not being able to access it. So the National Action Plan, which I don't think has quite been released yet, but there's been a lot of work over the past few years in our sector to try and get behind some shared priorities, so that we don't have a scattergun approach to the development of children's palliative care, that we sort of agree to focus on some key areas. And we have the sorts of things that will go with this and are in development are resources for communication skills training. We've created some podcasts, which you may be interested to listen to, with parents that are absolutely fantastic. And we're having those heard, listened to by parents around the world, and had some wonderful feedback about one parent in Africa, for example, who had an infant with a life-limiting condition, feeling very alone, and not necessarily having the energy to reach out to other parents, but finding the podcast extremely helpful in making her feel less alone. And she had it on repeat. So that's been a fantastic thing, I think, and a great resource for parents, but also for health professionals who want to understand a little bit more about the experience of parents who are caring for little children with serious illnesses. The other things that we're trying to do is get a good grasp of actually our population in Australia, who we're dealing with and to what extent we're meeting the needs. And, workforce planning is a really important thing. And I guess I can't really comment specifically on South Australia being a national group, but we have done some preliminary work on this and hoping to come out with something a bit more concrete. I think one of the fantastic things that has happened has been we have partnered with Palliative Care Australia and working with some absolutely fantastic colleagues there who've helped us with the various projects that we're working on. I guess they have a lot more experience and expertise in running large projects, but perhaps we've got some content knowledge to share. So it's been a really fantastic partnership with them. So I guess just to speak to the other couple of things being, we need to look at outcome measures in paediatrics. Peacock is one option, but another option that's coming out of the UK, King's College have developed a specific paediatric outcome measure, and most of the services in Australia have agreed to help validate that, so that'll start pretty soon. And as I say, you know, trying to take a collaborative attitude or approach to research. And I think if I come back to, you know, those very informal meetings we had before we were sort of a proper group, and John Collins, who was one of the early pioneers in this area, he really set the tone for us in paediatric palliative care in Australia to be very collaborative and very to share. I mean, always you will have competition, and that's healthy and that's good, and that helps progress. But I think another key thing is as much as possible to work together. And so I think we've all been taught how to do that really well from the master early on, and we've tried to hold on to that as a key value in our area. So that is us.
Thank you so much, Jen. Amazing to jump in at this last minute, and really appreciate you flying the flag for the team there. So much great things happening in the paediatric space, and it's really wonderful to see such a high profile of peds coming through on multiple levels. The document, the action plan is actually available on their website. So this is some screen prints on it. And I know that there is a question in there about these podcasts that you mentioned, Jen. So we'll share them with everyone. We'll get the link to that, share it out.
I'll send you the link. Yeah.
Lovely. Sounds absolutely fantastic, and so much greatness is happening in this space. So thank you so much.
Thanks, Charlotte. Thank you.
Lovely. Have a great day. And we'll hand over now to social workers. So the Palliative Care Social Work Association of Australia. And we're delighted to have Liz Wright present. Over to you, Liz.
Thanks very much. Is my volume okay?
Perfect.
Excellent, thank you. So I'm going to talk to you today about Palliative Care Social Work Australia, and I'm representing you as the Secretary of the Executive of PCSA. If I could have the next slide, please. I'd like to make an additional acknowledgement to country. PCSA, which is as we shorten our name from Palliative Care Social Work Australia, acknowledges the Aboriginal and Torres Strait Islander peoples, the First Nations, and their ongoing connection to land, sea and community. We acknowledge that the story and spirit of Aboriginal nations are written in the landscape of this country, and we pay respects to elders past, present and future, for they hold the memories, traditions and values which deepen and enrich the life of our land, communities and our nation. PCSA acknowledges the pain and impact of dispossession from land and the interruption to intergenerational inheritance of culture. We recognise this does not diminish the cultural and spiritual connections to country, but that it may have implications in the access to and provision of palliative care, end-of-life care and bereavement support. PCSA also acknowledges the resilience and strengths of Aboriginal and Torres Strait Islander peoples and adopts a position of cultural humility, making a commitment to promoting culturally competent, safe and sensitive practice in end-of-life care, sorry business and bereavement care. We extend, and I personally extend, warmest acknowledgement to any Aboriginal people who are with us here today. Thank you. If I could have the next slide, please. Palliative Care Social Work Australia is a relatively new organisation. It was established in 2020, 3 years ago. It grew out of the work of specialist palliative care social work interest groups that have been sprouting up around Australia since 2012. And those involved decided to collaborate initially in 2018 with developing, involving an Australia-wide working group for the palliative and end-of-life care social work standards. Next, please. Our team, the National Executive Committee, provide leadership and direct the work of the association. The executives is supported by the social work consultant leads and PCSA state network leadership teams, and we are all accountable to the membership. All the officers of the association volunteer their time in addition to their work responsibilities. So we don't actually have any paid staff, so that can get a bit challenging at times. I'm speaking to you today because I'm the only current member, South Australian member on the executive. We do have members of PCSA in South Australia, which I'm really grateful about. And my day job is I'm a palliative care social worker and currently the psychosocial lead for Central Adelaide Palliative Care Service. Next slide, please. And this is a layout of the team that the exec, which is made up of the chair, treasurer, secretary, a member secretary. We're doing a lot of work on social media and IT platforms and a national projects team. And we've also got social work consultants. We're trying really hard to build the expertise. There's a lot of very skilled social workers around Australia, and to fill those places. And the paediatric team talking most recently, it'd be great to have somebody in the paediatrics, First Nations and acute care settings. And we also have the state conveners. South Australia and Western Australia are currently endeavouring to develop a local branch. We're sort of putting a lot of work in, and South Australia will invite Northern Territory should we be successful in getting something going here. It's fantastic to get together. We have, you know, once every 3 months we have a meeting of the whole executive and leadership teams, and it's really quite inspiring to hear the work that's going on across Australia. Next slide, please. So PCSA's vision is to strengthen the voice of social work and to promote excellence in social work practice and in the provision of psychological, social, cultural, emotional, spiritual and practical support in palliative and end-of-life care and bereavement. Our mission is on the next slide. Palliative Care Social Work Australia is committed to the promotion of evidence-based, high-quality social work practice across all sectors of palliative, end-of-life and bereavement care. And again, please. So Palliative Care Social Work Australia has 3 primary objectives. One's advocacy, to engage in activities which raise the profile of social workers in palliative care, and such as members contributing to government submissions and position statements. And very importantly, to highlight the needs of clients living with a life-limiting illness and their support people. Next, please. Collaboration. PCSA is committed to collaborating to enhance partnerships and collaborative activities within the profession and with other organisations and agencies that we work together to provide services and excellence. It's very important to be PCSA to inspire and support social work leadership, research and evaluation, so that we can support professional development opportunities for social workers across Australia. Resources, the leadership group's working on developing some resources, and some members already have access to some evidence-based palliative care resources for social workers and can get into that through the members portal. We encourage members to submit resources for appraisal and endorsement by PCSA, and then they can be shared nationally. None of us are reinventing the wheel, and the author of anything is noted on the final product of the resource. And we encourage members to collaborate to develop resources as they become evident that they're needed for social workers and their clients. And next, please, PD activities. We've got online professional development activities, which are very well attended, and they specifically address palliative, end-of-life and bereavement needs, supporting people in these phases. I've mentioned the state and territory-based PCSA networks. These are peer-based groups to provide an opportunity to support, to share information and to promote palliative care social work within that state and territory. New South Wales and Victoria are really showing the benefit of this at present. Queensland's had a bit of a hiatus with some of the members taking a break, some of the leadership team taking a break. And as I said before, South Australia and Western Australia are working really hard to get on board. And next, PCSA have been involved in a number of position papers and publications, both academic and issue specific. Such as, so the activities to date, as I said earlier, there's this group has actually written National Palliative and End-of-Life Care Standards for social workers, established networks in Victoria, Queensland and New South Wales ACT. There's also the Higher Degree by Research Network to encourage social workers who are furthering their studies and the research that they're undertaking to be able to work collaboratively together. PCSA has co-established an international network to provide a voice, and have had so far 15 PD sessions which have been available online and well attended, and there was one whole day online conference when VAD was starting to be introduced to the States. And in addition to that, there's a range of submissions and consultations that PCSA is representing as part of. And membership of PCSA, its full membership's open to social workers who are members of the ASW. We encourage people to work in specialist palliative care service or hold an academic or supervisory role in palliative care. Although we also welcome members who are non-specialist palliative care roles, but in their work are providing social work interventions for people who have end-of-life bereavement or palliative care needs, and importantly, their families and caregivers. And of course, a passion and interest in achieving excellence in palliative care. We also have associate members. The associate membership is open to student social workers, to Aboriginal health practitioners, workers who work in palliative care service and have an interest in networking and education, mentoring, collaboration and consultation with other PCSA social work members, recognising that there aren't necessarily other opportunities and the importance of this connection. And for social workers who've previously worked in palliative care and maintain an ongoing interest. In terms of recommendations for priorities for palliative care, before I go on, I'd say that for PCSA, our recommendations are to continue prioritising advocacy for patients, families and the services, and to continue to develop PD activities for social workers. However, if we're looking at the broader picture, would encourage ongoing work to make palliative care services more accessible to the whole community, although with a particular focus on people who encounter barriers to accessing services, and they've been identified in South Australia's palliative care strategic framework. And our second recommendation is a really important one, and that's to advocate for services to enable people to be cared for in their place of choice. Recent changes in South Australia have meant accessing services for people and their families' carers under 65 is becoming increasingly challenging. And this is alongside increasing challenges across the board in accessing services, equipment, and support for carers to enable them to continue to provide care. They need some more backup. And all of this will help people to be cared for and die in their place of choice if that happens to be their private home. Particularly if they have an uncertain prognosis. These are services for people who've got a prognosis of less than 16 weeks, but there's a real need for people to have services earlier than that 16-week time to enable them to stay at home. This is assuming that this is that person's place of choice. It may well be that an aged care home or other alternatives, or they may be living in a different setting, and home's not an option, such as Central Adelaide Palliative Care works alongside SA Prison Health Services. There's a whole lot of other places that are people's homes. And we go back to two, I got sidetracked. Step down beds. It's really important to have a facility for people whose needs sit between an acute setting and home. And even more so since it's become increasingly challenging, almost impossible for under 65s to access residential aged care facilities. And we can always do with more hospice beds. And 3 is to continue to work collaboratively to provide education activities for the community in general and healthcare professionals in the provision of high quality and holistic, person-centred, family-focused and community-oriented palliative, end of life and bereavement care. Thank you.
Thank you so much. It's, I don't know about you guys, but it's so wonderful to see the Social Worker Association on this national front engaged in this space and doing a huge amount of work in the palliative care space. So congratulations to Liz and all your team as well. Lovely to hear from you and to see these really important priorities. Now we'll head over to public health palliative care, which we have Dr. John Rosenberg from up in the sunny state of Queensland presenting today. So John's the President of Public Health Palliative Care International over to you, John.
Thanks, Shyla. You can hear me okay?
Perfect.
Excellent. Thanks very much. Yes, I'm coming to you today from Kabi Kabi country, just north of Brisbane, and I acknowledge the First Nations peoples of Kabi Kabi land, and also any First Nations people present today in this seminar. I'm also pleased to tell you that as an international organisation, one of the things we've started doing, which I introduced as an Australian in our association, is undertaking a First Nations acknowledgement in our very big sort of public forums, such as our conferences. And of course, First Nations acknowledgements aren't commonplace in many, many parts of the world, particularly former colonial powers. So for us post-colonial countries to do so has captured the imagination of a whole lot of people, which I think is really important. Now, I promised Shyla that I would stick to 10 minutes, which is going to be a bit of a world record if I do. So look, this is words up here on the text, but I want to, I guess, communicate with you why public health approaches to palliative care are important. I'm going to ask you some two rhetorical questions. Interactively, I would ask you to answer them, but anyway, we can't do that today on a webinar. But on average, how many days does an Australian in their last year of life spend in hospital? Last year of life spent in hospital. It's 17. Okay, so somewhere between 2 and 3 weeks. And then the second question is, on average, what percentage of their time does an older Australian in the last year of their life spend in the direct care of healthcare professionals? What percentage of their time? It's actually 5%. And this creates what we call the 95% rule. First articulated by Professor Alan Kelleher, who is known to many of you. So 95% of the time, a person in the last year of their life is not usually in the company of healthcare professionals. And so who's doing it? Well, either no one, or a carer, or a small group of carers, or a network of carers, neighbours, community members, friends who rally around and are part of the support of that person. So public health approaches to palliative care are based on the idea that if we're really talking about palliative care being everybody's business, and if we mean it when we say that, we really need to, have this village supporting a person who's in the last year of their life, then it takes more than just services to do that. It requires an activated community. So for those of you who are familiar with the Ottawa Charter for Health Promotion, you'll know that there are 5 key action areas. These were promulgated in 1986, and they really demonstrate that health promoting palliative care is within the field of public health. And so as an association, we're based on these 5 kind of key action areas of the Ottawa Charter for Health Promotion: building public policies, creating supportive environments, strengthening community action, developing personal skills, and reorienting health services. And what that shows is that kind of full range from the civic life, health services, and then through to the community itself and it being activated in a way. Our role then is to promote this view and to support people educationally and in practice to meet health promoting goals in their approaches to palliative care. And often this is in partnerships between services, palliative care services, and communities who are willing to undertake that kind of deliberate approach to the support of people who are dying and those who grieve them, as well as care for them. We're building our research body, and people like myself and Jason Mills, I see you're on this webinar as well. And so, you know, there are those of us who are contributing to the building of the body of knowledge around public health palliative care and health promoting palliative care. Critical to it, though, is community engagement. And so this is not something else for services to do, but for a contribution that services who are familiar with palliative and end-of-life care issues can support. So we'll go to the next slide, please. How can Public Health Palliative Care International benefit South Australian? Well, it's really about pulling it down from a global perspective, which we have as an international association, to local. What can be happening in local settings in South Australia? And I've talked here about the compassionate communities movement, and that this is a way in which many places around the world are making real and making concrete and tangible that whole health promoting approach. And I am not across what you might be doing locally in South Australia with compassionate communities, but certainly that is something that is spreading around Australia. It's a bit patchy in terms of being a federated nation. We tend to rely very much on our state and territory boundaries to contain this sort of work. But it's really about looking at how a knowledgeable and informed community can support the needs that they identify for themselves. So this is not what health services necessarily can say, you know, have we got a deal for you? It's to use the expertise and support of palliative care services with communities in partnership. So it really does become everybody's business. Can I have the next slide, please? Before, actually, just duck back for me, sorry. Yeah. So I also wanted to sort of let you know about some of the things that we do as an association that might be of interest to you as South Australians. We have a number of global events that are available to members and non-members. Obviously, we are pleased to welcome new individual and organisational members. But these kinds of things are a series of ongoing webinars that look at specific areas of health promoting palliative care, public health palliative care, and compassionate communities. And they are, we circulate that widely, but you can go to our website. You can see the link there on the bottom of the screen. The 1st of November is International Compassionate Communities Day, and we started that, this will be our 3rd this year, and that's a kind of a rolling global thing. We chase the sun basically from New Zealand right around the world over a 24-hour period where local efforts and endeavours are showcased online to audiences that wish to dial in and out of those things. And so the first one was pretty impressive. Last year was a bit quiet, but it is an opportunity to see what's happening all around the world, and that really that this is something that's captured the imagination of the world. We also have a newsletter which we circulate every 3 months, and a number of toolkits that are available to assist you to establish compassionate communities in your areas. So I'll go to the next slide, please. We also offer endorsement as a compassionate community to those who seek it and meet the requirements. So I'm in my last minute, I think. Yeah, my alarm's about to go off. So some recommendations include identify the existing and professional resources and opportunities that you have in South Australia. Based on the principle of community development and health promotion, the first place to start with all of this is always, what do you already have? And so there are perhaps government policies, both at state and local levels. There are services that are already involved, and there are academic institutions and individuals who are already undertaking this kind of work. Finding those is the first step in order to utilise the expertise that already exists. The second recommendation is the same, but in the community. If you are looking at establishing a compassionate community in one of your South Australian towns or cities, then what's already there? What are the networks that are already there? How can that be harnessed in order to grow that? Find your champions, find your advocates. And then strategically co-design. It must rest on partnership. Talk to state and local governments so that there are policy platforms in place. Talk to the practice sector, the academic sector, and then become immersed within the community's life. And it's that process that will enable the kinds of things that Public Health Palliative Care International is promoting to happen on the ground. And so my last slide is a little plug. I know that we're all going to Melbourne for the PCNA conference, or at least I am, in July, but I'll see if I'm allowed also to go to our biannual conference. It's in Bern in Switzerland. You can see the dates there. It's going to be fantastic. It's coming together beautifully, and a very exciting opportunity to mingle with people from literally from all over the world who are doing this sort of work. So there you go, Shyla. I think that's a record. I've finished only probably a minute or so over.
Fantastic, thank you, and
you're welcome.
Yeah, thanks for monitoring your time for me and everything there. I think it's a very exciting time ahead. South Australia has got a lot of amazing innovations happening in the public health palliative care space, and talk a little bit this afternoon around what PCSA is doing, but we're actually partnering with the primary health networks and some other agencies to do exactly those three priorities. So
excellent.
Space, very exciting.
Yeah, that's great news. Thank you. Okay.
And we'll have to see how we can all get to Switzerland. I've got this whole conference list going on today. So yeah, it's busy.
I'll buy you a shardy if you get there.
Looking forward to it, Jen.
Okay, see ya.
Lovely. All right, now we're on to our last speaker. No, it's definitely last but not least. So Australian Centre for Grief and Bereavement changed their name last year, and now they're called Grief Australia. And we're delighted to have Chris Hull, the CEO, talking today. And we all know grief and bereavement is such an important space that used to get missed a lot in palliative care, but now it's such a high priority area. So thank you so much, Chris, for taking the time out today to have a chat with everyone in South Australia. Over to you.
Thanks, Charlotte. It's nice to join you and everybody else. And I'm privileged to be living and working in the beautiful unceded country of the Wurundjeri people of the Kulin Nation in the Yarra Valley in Victoria. So yes, we had a change of name. We were established in 1996, some 27 years ago, initially as the Centre for Grief Education, then some years later, the Australian Centre for Grief and Bereavement, and now the much more simple, straightforward Grief Australia. So again, a member-based organisation, and I look forward to sharing some of our work and what we do with you. So we have had a really strong bipartisan support of the Victorian government since 1996, and we receive recurrent funding through the Victorian Department of Health through the palliative care program. Having said that, our brief is much broader than palliative care. Perhaps palliative care clients represent about 10% of our work. But as part of that funding agreement, we operate a Victorian statewide specialist bereavement service. and that provides clinical supervision, secondary consultation, community support. We also receive currently funding from the Commonwealth Department of Health through the Aged Care program, and we're one of 4 organisations that have been funded by the Australian Government to deliver a COVID-19 grief and trauma response package to the aged care sector, and I'll speak some more about that in a moment. We also provide nationwide grief, loss and bereavement education in the form of webinars, courses, workshops, and also customised training. So the next slide, please. So, as I said, we provide a national program of support to aged care facilities and home care package recipients. So, this is grief and loss related to COVID-19. So we've seen more than 5,000 deaths in aged care settings. And so we've been providing clinical support, education and consultancy to aged care facilities and continue to do that work. We also provide a range of education and training opportunities. So we provide monthly webinars. Most recently, these have looked at kind of recent and emerging issues in bereavement support and care and research. We've done others on COVID bereavement, paediatric bereavement, and so forth. We also run a program of workshops, both person to person and also online, and also a conference program. So next year we'll be, seems to be lots of international conferences, but next year we'll be hosting the International Conference on Grief and Bereavement in Contemporary Society, which will take place in Melbourne. We also run a national certification program for bereavement practitioners. Given that bereavement practice is largely unregulated, we've been doing that national certification program for probably 4 or 5 years now. We've also auspiced the Australian Bereavement Network. Now, this is a new and developing national network of bereavement agencies. Really, its origins from a group of bereavement organisations in Sydney. And one of the elements of that work is to develop a national directory of bereavement programs. For somebody who works intensively in this area, it's very difficult to keep track of programs that are available. And so that will be a searchable database, searchable by either geographic area, type of bereavement. So we're in the process of developing that at the moment. That group has also developed a bereavement charter, which provides quite similar to what's been developed in the UK and in Europe, but really a kind of a statement of principles around bereavement care. And finally, we also have a free app called My Grief. We released that in Australia, the US and the UK, and it's been really well received. And it's designed for both those who are supporting a bereaved person as well as the bereaved individual themselves. And in the case of the bereaved person, it asks the person to respond to a number of prompts. And on the basis of that, they then provided with some tailored recommendations or strategies. We're currently doing a significant rewrite of that app, which we'll launch later this year, given that there's been a lot that's developed in the field since we launched that some years ago. And in addition to that, of course, we have broader engagement. Of course, we're actively involved in care search. We work in a number of other coronial jurisdictions. We also work with governments around work-related deaths and also victims of crime as well. If I could have the next slide. So in terms of priorities, I think what we currently lack is really solid, sound national or state guidance on bereavement care in the palliative care setting. A number of states from time to time have developed particular guidance, but there's certainly a real lack in particularly contemporary guidance around best practice bereavement care in palliative care. We know from Australian research that only 40% of those bereaved in a palliative care setting reported being specifically asked about their emotional and psychological distress before the death. And just half of the bereaved perceived that they'd received enough information or support from palliative care services. Half of the bereaved had a follow-up contact from the service at 3 to 6 weeks, and only a quarter had a follow-up call at 6 months after the death. So, this certainly qualitative feedback underlines the limited helpfulness of kind of blanket or general approaches to bereavement support. The National Palliative Care Standards, Standard 6 talks about the service employing a structured assessment of bereavement that addresses emotional, behavioural, social, spiritual and physical domains. And also that the service uses validated tools to assess for signs and symptoms of persistent and intense distress in bereaved persons. So again, the use of tools that help triage bereaved individuals in terms of the nature of support seems to be underutilised. If I can go to the next slide, please. So there is guidance available, although I'd argue now that it's becoming quite dated. There was a international systematic review of bereavement care practice guidelines, and they recommended 3. The Victorian Bereavement Support Standards, which was written in 2012, the guidance that really came out of the Centre for Palliative Care, and finally the New Zealand Mid-Central District Health guidance. So it's really time that this guidance was updated to reflect what we now know about grief and its complications. There's been enormous developments in the last decade, and I think there's a real value in preferentially a Commonwealth or a kind of a national guidance around best practice bereavement support in palliative care, or for states to continue to develop their own guidance. The second, if I go to the next slide, please, would be a greater focus on clients experiencing anxiety, depression and PTSD. And I think we've seen in certainly the aged care sector a move towards a more trauma-informed approach to care in the aged care setting. And I think we also need to embrace the idea of a trauma-informed approach, as well as a grief-informed approach in palliative care. So we know, again, with palliative care clients, between 12 and 59% of palliative care clients report significant levels of depression. We know that with palliative care, those bereaved in palliative care, between 30 and half of those clients have high levels of anxiety. And when we focus on that 10% of the bereaved population who have what's now called prolonged grief disorder, terribly disabling grief, only 32% of that group only have those complications around bereavement. In most cases, they're also dealing with PTSD, anxiety, or major depression. So I think it's really important that we broaden our focus around a more trauma-informed approach to the way we provide care. We're certainly seeing that. We're doing a lot of work in a number of states around VAD bereavement and high levels of self-stigmatisation in that cohort, where people feel they can't access support from mainstream services. So again, in many cases, there may be an overlapping traumatic component to that. And I think finally, and many others have made this reflection this morning, increased focus on underserved populations. We certainly see a lack of focus for children and adolescents. And similarly, in terms of Aboriginal and Torres Strait Islander people, the way we can actually enable and support those communities to effectively support themselves. And I guess from my point of view, when we, again, talking about the voice, the important leadership role of organisations have in supporting a yes vote, having identified those connections between identity and participation in policy development and social and emotional wellbeing. So I think in the next slide, and I think that's me done, probably in record time, but again, very keen to further the conversation with individuals either through our website or through email. My email is c.hall@grief.org.au. Thanks, Sharla.
Fantastic. Thank you so much. And it is so true what you're saying. There's so much going on in all these spaces. And even though you work in it, it's still hard to keep up. So having a summary like this of what's happening in that space is really important. So thank you.
Thank you.
Thank you all for your time. It's actually time for a lunch break for everyone now, and then we'll focus on the state update after that. So we'll come back together at 12:30 South Australian time. You're welcome to stay on Zoom and just sit there in this space while you wait, or you can jump off and jump back on. Either way is absolutely fine. We'd like to also acknowledge South Australian Government and SA Health team for supporting this event and supporting Palliative Care South Australia to understand what the collective voice for South Australians is in this space. We'd like to thank all of our amazing speakers who've spoken so far, and we've got lots more to come from the South Australian space. So really hope that you stay online and jump back in at 12:30 South Australian time. A bit of an update on the screen at the moment of what we'll be doing with everything. You will get an email summary of this in the next couple of days, and with some links that we've talked about so far, particularly all those conference links that have been coming out. And also the presentation will be available on YouTube as well. And there's lots of different ways that you can get involved with Palliative Care South Australia so we can keep this going. We'll give you a bit more of an update after lunch. So go and enjoy yourself, have a bit of time for your feet up, have a bit of a rest, and we'll see you all at 12:30. Thank you.